Hello everyone and welcome to today's webinar. Today's topic is Introduction to Bowel Cancer and Screening. My name's Jane Henty and I'm a project manager at APNA. I've left my contact details on the screen if anyone wants to follow up with me after the webinar. So firstly, I'd like to acknowledge the traditional custodians on the land on which we're meeting. I would also like to pay respect to Aboriginal elders both past and present and extend that respect to other Aboriginal people on this webinar today. This initiative is funded by the Australian Government Department of Health. The webinar is delivered by Australian Primary Healthcare Nurses Association with the support of Cancer Council Western Australia. This webinar is live and interactive, so you're encouraged to participate by posting questions to the presenters, which can be typed into the chat box at the bottom left-hand corner of your screen. All questions will be answered at the end of each presentation. If you experience any difficulty during the webinar, please dial the 1800 support number listed in the chat box. So, I'm pleased to welcome our presenters for today, Dr. Hui E and Tracy Murphy. Dr. Hui E has been a full-time gastroenterologist at St. Charles Gardner Hospital in WA since 1998, where he's also held previous roles as head of the department and director of endoscopy. He is the clinical advisor to the Department of Health WA on strategic and operational issues pertaining to the National Bowel Cancer Screening Program. He has also been co-opted to assist with revising the NHMRC's Clinical Practice Guidelines for Prevention, Early Detection and Management of Colorectal Cancer since 2015. His current clinical interests include gastroenterology, genetic colorectal cancer syndromes and endoscopy performance. And Tracy. Tracy has worked in general practice since 1998 in Mildura and Ballarat. She's also worked as a solo women's health nurse for Women's Health Loddon Mallee for 8 years. Her main areas of interest are both health promotion, preventative health, women's health, youth health and nurse-led clinics. Tracy has completed a Masters of Advanced Nurse Practice in Primary Care in 2012 and now coordinates the Postgraduate Diploma in Primary Care Nursing at the Department of General Practice at the University of Melbourne. So now I'd like to hand over to Dr. Hui E for his presentation.
Okay, thanks very much, Jane. Good morning or afternoon, everyone, depending on where you are. It's hard to believe that there are probably over 500 people at this session. You wouldn't know that sitting where we are. I'd like to talk to you today about bowel cancer screening, especially in the context of the disease itself, the significance of the disease and why screening is important, and then touch on the National Bowel Cancer Screening Program. But before I proceed, I also would like, on behalf of the Cancer Council and all of us here, to acknowledge the traditional owners of the land, the Noongar Whadjuk people, where we are in Subiaco, Western Australia. We would also like to pay respect to the elders, both past and present, and offer our acknowledgement and respect to other Aboriginal and Torres Strait Islanders who are present. Suffice it to say, I feel that it's a great privilege to be able to be conducting our work here on Noongar land. Okay, on to bowel cancer screening. If I move to the first slide, these are all new technological experiences for me, so excuse me if there are minor glitches along the way. The first slide here aims to show that bowel cancer is a very important disease in this country because it is very common. If you look at males, it is the second commonest cancer after prostate cancer, and I'm talking about internal cancer here, after prostate. And if you look at females, it's the second commonest after breast. Of course, thankfully, I don't know any females who've ever had prostate cancer, and breast cancer in men is very uncommon. So when you combine the two together, colorectal cancer is a very important cancer that affects both males and females. So if you look at it at a global level, internationally, Australia and New Zealand have one of the highest incidence of bowel cancer in the world. In blue, you can see the incidence. And if you look at mortality, it is also very high, as is the case in a lot of Western countries. So to summarize those comments, Australia and New Zealand has the highest global incidence of bowel cancer. It is the most common cancer which affects both men and women, with a lifetime risk of about 1 in 10 for men and 1 in 15 for women. And it's the second biggest cancer killer in Australia after lung. In 2016, 17,500 people were estimated to have been diagnosed with bowel cancer, and 4,000 people have been estimated to have died from it. The incidence is set to increase because of the aging population and also certain perpetuating lifestyle practices. If we look at the incidence by age, we can clearly see that bowel cancer is typically a disease that starts to become a problem from middle age onwards. So young people below 40, it's relatively rare, but the action starts to begin after that, especially from 50 onwards, where the growth of incidence becomes exponential. If we look at survival, fortunately, over the last 25 years or so, in the 1980s, people who were first diagnosed with bowel cancer, about 50% of them would die of the disease. But over the ensuing 25 years, because of earlier diagnosis and especially better treatment options, nowadays 75% of people who are diagnosed with bowel cancer will ultimately survive it. So that's a significant improvement in survival. What is this entity, bowel cancer? Well, it is the end of the road, if you like, of something that initially begins as a collection of rogue cells which grow in a very active fashion, which starts off forming a small, tiny lump called a polyp, which may be first noticeable after it is only a few millimeters in size. Over many, many years, and the sequence we're talking about is 5 to 15 years, the cells become, the lump becomes larger and larger, so the polyp gets bigger and bigger, and ultimately they have the capacity to start eroding and invading into deeper structures, and also the potential to metastasize. And at that point we call it a frank cancer then. So it is really a continuum which begins over many, many years. The important point here is that if we can remove these early lesions, these early polyps, we will stop cancers from ever forming. It's important to know that it's a slow process, and once removed, the cancers will not form. But of course, new ones can grow. So it is also important to understand that just because things are cleared out at one point in time, it doesn't mean new things won't happen again in the future. Finally, it's also important to put into perspective the fact that the vast majority of polyps actually do not end up being cancer. They may just continue to become larger and larger polyps or stay the same size throughout the lifetime of an individual. When cancer is diagnosed, it's divided into numerous stages depending on how advanced it is or how deep it is spread. So stage A is the earliest, where the cancer is confined to the superficial layers of the bowel wall. B is where it has advanced a bit more, so that it has penetrated through the outer muscle layer. C is when there is lymph node spread, and D is what we call metastatic disease. It has gone to other organs, such as the liver and the lung. And together with that, the importance of this is that there is this direct relationship between the stage at which it is diagnosed and the survival. So that if it's diagnosed at stage A, there is a very good survival, 93%, whereas as the stage becomes more advanced, the survival starts to drop, and of course by the metastatic stage, the survival at 5 years is only 8%. So this is a very important point in terms of the biology of bowel cancer, because early detection is a very important thing. If found early, up to 90% of bowel cancer can be cured. Risk factors are very important. There are non-modifiable and modifiable risk factors. The most important of our non-modifiable ones is probably age. So as I've shown you in the earlier graphs, from about 40 and especially 50 onwards, that becomes a significant risk factor for bowel cancer. Of course, having a personal history of bowel cancer or certain forms of bowel disease, a family history, and also having other genetic susceptibilities increases your non-modifiable risk. But I don't want to overestimate that, because really only probably about 30% of the overall bowel cancer risk is determined by these non-modifiable factors, Whereas the modifiable factors, including dietary factors, obesity, physical inactivity, red meat consumption, alcohol, smoking, etc., cumulatively add up to a very substantial component of the risk of bowel cancer. If we look at the next slide, if we look at the modifiable risk factors, you can see inadequate dietary fiber consumption will contribute to about 18% of the risk. And this should be seen as both to the population and also to the individual, so that as more and more of these things add up, you can see that the risks of modifiable factors become higher and higher. So red meat and processed meat, about 18%, alcohol, physical inactivity, body fat, smoking, all of these all add up, and cumulatively, before you know it, you have 50 to 60% increased risk of bowel cancer. A very important thing that we need to know is that bowel cancer at the early stages, definitely at the polyp stages, meaning before it has become cancer, is essentially asymptomatic. However, by the time it is big enough, it will present with a few things, such as rectal bleeding, such as anemia, especially iron deficiency anemia, changes in bowel habits, alternating constipation and diarrhea, for instance, abdominal pain, and unexplained weight loss. Unexplained weight loss is a tricky one because largely the real concern is when there is that plus some other bowel symptom. Then we know we are likely to have trouble. So why do we talk about bowel cancer screening? The intention of screening is really to try and focus our resources so that we do fancy investigations like colonoscopy on the most targeted people, the people who need it most. So it improves our limited use of resources, and I'll show you evidence for that later. But we also know, because of our understanding of the biology of bowel cancer, when you detect it early, there is a much greater chance of survival. I'll also explain to you that no screening test is 100% accurate, but the intention is not to diagnose, but to use it as a way to channel our resources better. And we know, as I've said to you before, at any one time there may not be cancer, but in the future, after many years, new cancers can develop, so that screening must be seen as a repeating process, not just a one-off. Of course, it's important to re-emphasize that screening is not a diagnostic test. When people have symptoms, they need a diagnostic test, such as colonoscopy. If you look at the World Health Organization guidelines for screening, bowel cancer is an ideal disease because it is common and definitely very serious. There are no symptoms during the early phase, so we should use a technology to try and catch it before the symptoms are evident. We know that when we remove the precursors, such as polyps, we will stop cancer from forming. We know that earlier detection makes treatment simpler, and earlier detection will also improve survival. Already for 25 years nearly, there have been proven safe, effective screening tests that are available, which have been shown in large populations to actually save lives. So the question is, let's get on with it. And indeed, even as early as 2005, 12 years ago, the National Health and Medical Research Council, together with the Cancer Council, put up documents which recommended that asymptomatic individuals should undergo organized screening with a test called the Faecal Occult Blood Test, performed at least every 2 years from 50 years onwards. Of course, it's different to people who have symptoms, such as bleeding and so on, where they need definitive investigation. I stress that repeatedly. Screening is essentially for asymptomatic people. So what is this FOBT business? It's the Faecal Occult Blood Test, and there's an I which we tag on nowadays because the newer technology uses a thing called an immunochemical test. It is a type of stool test which has a sensitivity of 83% for detecting cancer, meaning that if there's a cancer there, it will detect 83% of the people with it, which of course means that 17% of people with cancer may still be missed. That's important to know, but shouldn't be too much of a distractor. There is a positive predictive value of about 5% for cancer, meaning if you do the FOBT and are positive, the patient will have a 5% chance of having cancer, but equally they will also have significant chances of detecting advanced polyps or adenomas, and also some less advanced adenomas. And detecting these adenomas and removing them actually results in a significant reduction in the risk of future cancer, because cancers arise from adenomas. So this focusing business I was mentioning before is really the point that someone who has a positive FOBT is 12 to 40 times more likely to have bowel cancer than a person with a negative test. So this is the importance of the focusing. We are picking people who are much more likely to have this condition. It has a high specificity, meaning if there is no disease, the test will be negative. So it's important to emphasize FOBT is not a diagnostic test, but it is the best test to use for screening the population. Some things can be confusing because sometimes blood can also arise from hemorrhoids, menstruation, from diverticular and so on. And sometimes the false negatives can also occur when bleeding from cancer is only intermittent. Sometimes there is some poor distribution of the blood within the feces at the point of the testing, and there are some technical reasons why the test can also be negative. Also, when there is no cancer at one time and a person has a negative test, it does not rule out getting cancer in the future. So again, I state the importance of having the test seen as a repeating event. Why screen over 50? I've told you before, over 50, when you look at this graph, is the exponential point of growth, and you can see this is where the action is. When you start doing tests at this age, this is where you'll find the trouble. If you test people who are too young, the yield is too low. There are a few other things which are also frequently discussed, such as family history and so on. And it is very important to realize that the vast majority of people, well in excess of 90% of people, are actually at a level of risk which is not especially high, meaning that they have no personal or family history of cancer, or their close relative with bowel cancer was diagnosed at a late age, over 55. Their overall risk of cancer is at most twofold, and they do not need to have any fancy screening. They can just undergo the Faecal Occult Blood Test. There are other people with higher risk, though. They might have family members, close family members who have cancer diagnosed below 55, or more than one relative on the same side of the family. Their risk goes up to about 4 times, and there it is recommended that probably they should have colonoscopy from a certain age, like 50. Then there are even higher risk groups, such as with many relatives, with past history of polyps, with past history of cancer, people with inflammatory bowel disease such as Crohn's and ulcerative colitis, and people with type 2 diabetes, because insulin growth factor can act as a bit of a tumor promoter. So these people may need to go straight for colonoscopy rather than the FOBT. Finally, there's a very high risk group of known genetic syndromes. These people usually know they are already in there. They might have had genetic testing because some relative has it. And these diseases have names like familial adenomatous polyposis or Lynch syndrome, which is also called hereditary non-polyposis colorectal cancer. These people have very high risk of cancer, between 50 and 100%, and they go straight for colonoscopy, sometimes every year, and some of them might even have preventive colectomies, prophylactic colectomies. Okay, symptomatic presentation. When someone presents with cancer by the path of having symptoms, 25% will ultimately die from their cancer because it is at a sufficiently advanced stage where it is not simply curable. Over 95% of them will need surgery, and only less than 5% have such a small chip of cancer where colonoscopy and removal with polypectomy will get rid of the cancer. So we can fairly say that most bowel cancers present late. It makes good economic sense to screen because when you look at the staging that I told you about, 1, 2, 3, 4 and ABCD are the same sorts of terminologies. If you find a cancer at stage 1, the cost to treat them is about $30,000, whereas as the stage increases, the cost becomes more and more than doubling by the time they're stage 3 because they often need chemo plus or minus radiation. And at stage 4, where it's incurable, they use very fancy and very expensive medications, but the cost drops because they probably are too late to need surgery anymore. And when you look at the National Bowel Cancer Screening Program, and I show you on this graph here, the red is the NBCSP. The beauty of this program is that it is finding a lot of people early. So at stage A, there's lots of red. And at stage D, which is incurable, the Bowel Cancer Screening Program cases were often not found at stage D because they were all found earlier. Whereas in the blue, which is the symptomatic presenters, there were not so many found so early, and there were quite a few who were found much later at stage D, which is incurable. Of course, if we find precancerous polyps and remove them by endoscopy, meaning colonoscopy, it's much cheaper. It's only $1,000 to $2,000, and there you've prevented the cancer. In the last 25 years, the cost of treating bowel cancer has significantly escalated. It's now well and truly over $1.2 billion a year. And this is because there is more of the cancer now due to rising incidence, and the new treatments, especially new chemo and biological treatments, are very expensive. So there's a very important cost imperative, which comes back down to this very important initiative called the National Bowel Cancer Screening Program. It started in 2006 when a chappie called Tony Abbott was the health minister. And at that time, only a few ages were involved, but now the program has spread to involve people who are at 50, 54, 55, 58, etc., all the way to 74. And ultimately, in 2019, it'll be every 2 years for age groups in 2-year gaps between 50 and 74. And that will be called a full rollout. So it'll be a complete program by then. The program runs like this. There is a pre-invitation letter to say, warning, warning, we are going to send you a kit. Then a few weeks later, and this happens soon after your appropriate birthday, so it's like a special birthday present from the government. They send you the kit. They recommend that you perform it. And if you have a negative result, the person is asked to, I shouldn't say you, I mean the participant is asked to re-participate again in a couple of years when a new kit arrives. If there's a positive result, the GP is also informed, who then organizes a colonoscopy for the participant. And if the colonoscopy is all clear, they rejoin the screening pathway again in a couple of years. Or if the colonoscopy finds something, they will need specific treatment, be it polypectomy or even surgery and treatment if a cancer is found. This is what the kit looks like with these 2 tubes, which are done in sequential bowel motions with a mailer bag package, which you send back to the lab by post. But the big problem with the program is that the national participation overall is only 38.9, so less than 40%, when in fact the more people who participate, the more cost effective it becomes. You can understand more lives will be saved and more cancers will be found earlier. There are state-to-state variations, but 38.9 overall is not fancy. There will be a new cancer screening register for both bowel cancer and cervical cancer participants, which will be a single electronic record, which will be used to send invitations and reminders, and it will be accessible by health professionals as well as the individuals to work out where they are in the program and whether a new kit needs to be sent out early and so on. So overall, when you look at the overall performance of the program, only 39% participation, fewer males than females, which is not unusual, but should be something that needs work to be done. Of these participants, 7% are positive, and overall, 3% of people will have either a cancer or an adenoma found. But the main point is more cancers being found at earlier stages result in better prognosis. So finally, to wrap up, a bit of extra information here in terms of contact and so on. So that's the end of what I want to say. I will hand back to Jane or perhaps Tracy. I'm not sure. Or I think we have some answers, questions to answer at this point, I think. Thank you.
Yes, thank you, Huey, for your presentation. So we're now inviting questions from the audience. If you'd like to ask a question, can you please type your questions into the chat box at the bottom left-hand corner of your screen? And I can see that we've already got some great questions here. Huey, Belinda's asking, if cancerous polyps are found once, is it more likely for them to occur again?
So the answer is yes. It is slightly more likely for them to occur again, but once cancerous polyps are found, these people go into a colonoscopic pathway where they periodically will get colonoscoped. And because of that, because of the chance by colonoscopy detection of earlier lesions from here on in, they virtually will never get another cancer again, provided they keep turning up for appropriate colonoscopies at appropriate intervals.
Great, thanks for that. And Victoria's wondering, is routine testing, oh, there's so many questions there going down my screen. Is routine testing recommended after the age of 74?
Okay, so the answer is no. Routine testing is not recommended in asymptomatic people after the age of 74, largely because it is not deemed to be cost effective, and because beyond that age there is significant comorbidities and so on, and so that the risks of the extra survival that will be created by detected cancers then will compete against other things that threaten survival, such as cardiovascular morbidity and so on. So in most analyses here and worldwide, we would not recommend routine screening of people over 74. This is an entirely different, if I just extend it further, it is entirely different to symptomatic people. So if someone says they have overt rectal bleeding, that's an entirely different scenario.
Okay, thanks for answering that question. And our next question from Patty. Are vegetarians less likely to get bowel cancer?
So the answer, this is the answer is that on the whole, by having a diet which is high in vegetarians, the answer is that it will reduce a significant component of the risk. So I don't know whether a specific study has been done, but there are many circumstantial pieces of evidence and big population studies which suggest that a higher vegetarian diet will reduce the risks of bowel cancer.
All right, great. And our next question is, what is the nurse's role in screening, e.g. with general practice? And I'd just like to make a note on this question. I think Tracy's going to cover that in her next section. So we might skip over this question, and I hope it will be covered in the next presentation. But if not, please re-ask your question at the next question time. Our next question from April. Should all polyps need to be biopsied or removed?
Okay, so as a general rule, the answer is yes. All polyps, all adenomatous polyps should be removed. There are other types of polyps called hyperplastic polyps. There are hyperplastic polyps that occur in the sigmoid and rectum, which is the lower part of the bowel. They can be very common, and after an initial sampling to show you what they are, some of them are not removed. But adenomatous polyps, which are the polyps which become cancer in the future, the recommendation is yes, they should all be removed.
Okay, thanks for that. Next question is, can hemorrhoids turn to cancer?
Okay, that's a simple one. The answer is no. However, the trap here is we cannot assume hemorrhoids unless we have excluded cancer. All right, so hemorrhoids can present in a way that so can cancer. And we can't just assume that the problem is hemorrhoids. We must always exclude cancers, such as with an appropriate examination, like a colonoscopy. And then after that, we can say, yes, it's most likely due to the hemorrhoids.
Okay, thank you. So Sonia's asking, hi, so all bowel cancers start from polyps?
So that is a very tricky question, meaning that almost all do, but there are some unusual cancer types where it starts more like a flat sort of lesion or a flat burrowing sort of lesion. So it may start like an ulcerating divot rather than a poking out lump. And so it's a long-winded way of saying most cancers start by polyps, but some start by a deeper infiltrative form, but they are very unusual.
Mm-hmm. Now, next question. If a person does not complete the kit on the year it was sent, will they receive a kit in the next year or 2 years later?
So I think that the way the program is, they will give you up to a year, after which if you don't participate in that, that expires your shot for them, and then they say join up again in 2 years. So in that 1 year in between, no, the program you can't participate in that if you've missed it for that year.
Okay. Now, Tanya's asking, who can patients contact if they've lost their FOBT kit?
Okay, so there are these numbers that we've put at the end of the last of my slides, but there's a National Bowel Cancer Screening Program information line, for instance, and there's a number there attached. They can Google the website for the National Bowel Cancer Screening. Oh, well, thank you, put that slide on there. Thank you. 1-800-118-868 is the information line.
All right, great.
Like I said, they give you about a 1-year grace period.
Mm-hmm. Elizabeth's asking, if patients are having 5-yearly colonoscopy, do they opt out of FOBT?
The answer is they probably should, because colonoscopy is much more accurate, and they are people who have been targeted because of whatever reason, some of the reasons I mentioned, such as previous polyps, previous cancer, significant family history, etc., etc. So they are people who need to go through a more advanced and invasive test.
Okay. And Michelle's asking, what is the role of MRI versus colonoscopy in early diagnosis of symptomatic people?
Okay, for symptomatic people, at the moment MRI is unproven, but there is another technology called CT colography. CT colography is an acceptable way to also diagnose cancers, but you can't get tissue specimens and you can't remove polyps with CT colography. So it hasn't really taken off very much. It is sometimes used in people who, for whatever reason, cannot tolerate a colonoscopy. So there are alternative technologies, but if they can tolerate a colonoscopy, it is the superior investigation.
All right, great. And this will be the last question. And I'll just note here that we'll keep a note of all the questions. It's great to see how keen people are on this subject, and we'll endeavour to answer all the questions after the webinar if we run out of time. So the last question is from Kerry. She's asking, how much is too much processed meat?
That is, some is worse than none. So that's a very difficult question, because some is worse than none. There is, as little as possible is better. And the same with red meat. We are not saying no red meat. We are saying probably something in the order of about a palm-sized serving, about 3 times a week max, and not overburning it. So, of course, I think a daily serve of processed meat is probably, we should try and cut that down.
Okay.
Less than that. So perhaps
Thank you
2 or 3
very much
times a week.
Thanks, Huey, for answering so many questions in a short bit of time. Now, I'll move on to Tracy now for her presentation. So, welcome, Tracy.
Okay, thank you, Jane, and thank you, Huey, for that presentation. It was really interesting. I'm going to change the tempo now from the science and statistics to the practical. Only I'm not, because my button's not moving. Okay. So you can see from the learning intentions, some of this presentation will build on some of the information that's already been presented, but I'll mainly be focusing on practical aspects of screening and health promotion in the practice and facilitating conversations about screening with patients. Firstly, I want to stress that screening is for people without symptoms of the disease, and if your patient's telling you that they've got any of the following symptoms, then they should be seeing the GP rather than completing a screening test. If they've seen blood in the toilet, then their screening test is already positive. And we can facilitate patients making an appointment with the GP. We can let the GP know what's going on, especially if we think the patient might be a little bit reticent about talking about blood in their poo. And similarly, if you identify a patient with a strong family history or with bowel disease, such as Huey's mentioned in his presentation, then they should be going to the GP and discussing what the most relevant screening is for them. So I know I'm talking to the converted today because you're all listening to this webinar, But practice nurses have got a lot of competing demands on their time, and you might find you have to make a case for increasing your role in screening. And what I suggest is you ask, is this an important issue for my patients? And I think that the previous presentation has given us a definite yes to that. Is it relevant to your role? And the national standards for nurses in general practice clearly state that evidence-based health promotion and preventative care is part of the practice nurse's role. And is it something that can easily be incorporated into your routine work? And I'm just going to discuss some strategies for this later. And lastly, if you need to influence key people to get them to allow you to increase your role in screening, get them to watch some of the videos and the stories about bowel cancer. They're really powerful. So having established this as our role, we need to think about how we can identify patients. And when I see a patient who's coming in to me for a women's health consultation, the first thing I do is look at their age. That tells me an awful lot about what I'm going to be talking about and what kind of screening they're due for. Family history is something that is often out of date. It may have been done when the patient first came to the practice many years ago. So that's something, if you don't already update family histories, to get into the habit of asking when you've got a few moments, like when you're waiting to complete a second spirometry, you've given them the Ventolin, you've got 10 minutes there. Or when you're doing a wound dressing, you can just verbally be asking if anything has changed in their family history. There is a family history questionnaire in the RACGP Red Book for its preventative activities in general practice. If you've not seen that, you can download it from the RACGP website, and it's a really useful, the whole publication is very useful if you're interested in screening. Let the GP know about any significant changes in family history, and these people may require extra or earlier tests. So at 50, as Huey says, you become a person of interest. It's the only gift you're ever going to get from the government, so do it. When you look at those statistics of screening for the other programs like mammograms and cervical screening, I'm always amazed that this test that you can do in the privacy of your own home, that is easy and that is free and convenient, just doesn't have the uptake. And I wonder whether it's because we've been promoting breast and bowel and cervical screening to women for a long time, and now it's time to promote the bowel screening, and maybe we can see a rise in that rate. So now you're keen to start talking to people about screening. You need to know a little bit about the program, and we've already said that it's building up to offering people a test every 2 years. If you've got a 49-year-old there, 45 to 49-year-old health check, let the patients know they're going to receive an invite. If they don't want to receive kits, they need to send the paper that comes with the invite back. Otherwise, they'll keep getting them every 2 years. Let them know that you recommend it and that their doctor recommends it. There is evidence that personal recommendation does increase screening rates from a health practitioner. Now, you can check online for when you're due a kit, or you can ring the information line. If you've got a patient and you know they're going to struggle to do that, then you can help them by looking that up on your computer. Eligibility, basically, if you've got a Medicare card, you're eligible. If you're not eligible, or if you want to screen 2 yearly and you're in one of those age groups that isn't yet getting the 2 yearly screen, GPs can order a screening test and they'll get a Medicare rebate. There are 3 charities that have done a fantastic work in promoting bowel cancer screening and supporting the national program while it was in its infancy. One advantage of their tests is they use a paintbrush, and it's got a long handle. It's easier to hold, and some people prefer it because they're further away from the poo end of stuff. The big disadvantages for these kits, though, is a cost is involved, and these tests do not go on the program registry, and they won't go on the new National Cancer Registry. And because of this, patients won't receive follow-up. With all tests, the patients will get a letter telling them the test is positive, and that can be a source of anxiety. And that can be relieved by the practice nurse. Actually, when you see the GP's letter that tells them their patient's got a positive test, the practice nurse could ring the patient, or if it's the receptionist or the practice manager ringing the patient to get them to make an appointment, they can offer, do you want to talk to the nurse, especially if the patient seems unduly anxious. What you should say is to reassure them that just because they've got a positive test, that doesn't mean it's going to be cancer, and that because it's been detected early, treatment is very successful. So just to reiterate the benefits of the National Bowel Cancer Screening Program, it's completely free. You get an invitation letter, you get a reminder letter if you forget to do it. There's follow-up support, and that includes letters to both the GP and the patient and telephone calls as well. And in some states, if you've had your screening test through the National Bowel Cancer Screening Program, your follow-up colonoscopy for a positive test is actually prioritized. And there are some stickers that can go on your referral form to say this patient is a patient of the program. But of course, lots of people are doing it with Argus now. So again, that's something that your practice manager or whoever types the referral letters can put a note on that referral letter that this patient is an NBCSP program participant. I just wanted to say a word on choice. We're not there to persuade people to do the test. Our responsibility is to provide jargon-free information so that patients can make an informed choice. And that choice might be that they understand that the test would be beneficial to them, but they're still not going to do it. In that case, what we need to do is document the information we've given and their response. But people do change their mind, so always check. In a couple of years' time, you might say, hey, Bill, we talked about bowel screening last time. You said you didn't want to do it. Is that still the case? And always leave an open door so patients know they can return to see you about bowel screening in the future and know that they won't be judged. So how do we talk about poo? One really easy icebreaker is to have posters and brochures in your waiting room and in your consultation room. And when you've got sensitive information, it's a good idea to put it in the toilet. We do that with violence programs so that people can read it in private. Having a poster in your consultation room in your line of sight will help you to remember to ask about screening if it's not something that is usual for you to do. When you're doing a procedure, you can just ask the patient to have a look at the poster or hand them a brochure and just ask them what they think about the program and whether they've done it. So I asked lots of people about bowel screening, and I just put down some of the reactions I get. So most of them pull a face. They don't like the idea of putting the poo in the fridge. And it's important to show them the container, and I think you can see from that picture before, there's a stick inside a container that then goes inside another container. And the idea is not to make a poo chupper cup. They don't need a great big blob of poo on the end. It will really just be a bit of a staining, so they're not putting a lot of solid into the fridge. If they're really worried, they can put it in another plastic container for extra security. They can use the outside drinks fridge, or I do say someone else's fridge. I've put a cooler and I realised that that's an esky in Australian. You have to be careful with that because it's not like a beer, and if you fill it with ice and you stick the thing in it, it'll freeze and then it's no good. So you'd have to pack it like you would for immunisation. So that's probably really a last resort. Patients do the test on Monday. They'll do the second test on Tuesday. It will be in the fridge for a very short period of time. And that's also important in summer because you don't want someone to put it in the post box at 6 o'clock on Friday night, and it's not going to go now till 1 o'clock on Monday. We do ask that they hand it into the post office, especially in summer, so at least it is in the cool post office rather than in a 41-degree box outside, and I guess they probably get to 60 degrees because they're metal. Runny poo and the sinker. If you do a big poo, it will sink the paper, and the stick is short, which means you might get your hand wet. And if someone has very loose stool, then it just mixes in, and there's probably nothing to put the stick through. So an ice cream container, and you put the paper in, It will keep the solid there. Once the test is complete, just drop it all down the toilet. You could also put a wad of toilet paper underneath the paper, but you've got to be careful not to block the loo, and some people might like a free disposable glove. I didn't get it, I've lost it, or it's still in the cupboard, or I threw it away. I spent a lot of time looking for the expiry date on the outside of the box. It's not there, it's on the sticky label inside the kit with the sticks. They can request a replacement kit by calling the program. You can also ring this number to opt off, because otherwise you're just going to keep getting them. To suspend it if you've had a colonoscopy and you don't want to do it now, or if you've changed your mind because they've listened to what you've said and now they think it's great and they want to go back on the program. This has already been addressed about already having colonoscopies, and really it's speak to the specialist or the GP, but what is really important is that if you develop new symptoms between your colonoscopies, that you go back and see your GP. Keep forgetting. Ask them where the test is. You usually find it's in a cupboard in the kitchen. That's no good. It needs to be in the bathroom, needs to be visible, and use whatever reminder you usually use. So that might be, if you have a coffee in the morning before you go to the toilet, a sticky note on the milk or a sticky note on the coffee, or a piece of red string tied around the bathroom door would annoy me so much I would have to do the test to get rid of that piece of string. And if people are a bit forgetful, do remind them, don't forget to enclose the completed participants' details form in with your sample, or you're just going to have a lonely sample that goes back to the program. Some people are really afraid they're going to mess that up. That kit does look very scientific, and they think if I do this wrong, this might affect my health. As nurses, you can obtain a demo kit by emailing cancer screening, or you can show them the video. And I've put there a partner may help, and I haven't actually found anyone who would agree to this, but if you had someone who was blind or had difficulty using their hands, then this may be a conversation that as the practice nurse you could have with a partner or a carer about helping that person complete the kit. This is another one I get from the women. Isn't it for men? I think they think they've done the bit once they've got the mammogram and the pap test done. You can see compared to the other female cancers that this is really important, and compared to cervix, which has a 60% approximately participation rate, it's a tiny number. And as he said, bowel cancer is the second most common cancer in women, and most people do not know that. So, having done this, listened to this webinar, you may be all hopefully fired up and ready to go and ask everyone to do the test. But you might only see 10 people who are eligible for the test on one day, whereas there might be 50 people actually have attended the practice. So a whole of practice approach will increase your reach. Put it on your practice management team meetings. Decide what resources the practice is prepared to invest. It will cost time and money to actually have a health promotion program. There is a GP letter or a GP template that can be sent to patients before they're turning 50, and there is evidence to show that a letter that has the GP's signature is effective. And whatever you do, it needs to be simple. And if you involve the whole practice, it will spread the workload, and as practice nurses are very busy, you simply can't do it all on your own. Some ideas: receptionists and practice managers can be involved in data cleansing and running reports. If you're going to spend the money on sending out a letter to your 49-year-old, you want to at least know they still come to the practice. They can ensure that the NBCSP participant information goes on any referral letters, can update and rotate and order health promotion programs, posters, and use people's strengths. So if you've got a very creative receptionist, she might be able to make a beautiful display. I can't do that, but we have one very creative receptionist in our practice. Or you might have a young receptionist who's a whiz at Facebook and who can link bowel screening information onto the Facebook page and even tell you how many likes you got and how many people have visited your page. And that's a morale booster to tell people every week how many more likes you've got. Nurses, if it's not already there, you can get family history and bowel screen added to your health assessment and CDM templates. Because you're very busy when you're doing these CDMs, if you've got to bring someone back for follow-up for a 10997 for their BP or something like that, then you can take that opportunity to explain the test. And chronic disease is linked to bowel cancer. You've got the same risk factors, and as we said, type 2 diabetes is a risk factor. And add cancer prevention to your reasons for suggesting changes to diet and exercise, etc. Health promotion, to actually do your own health promotion program is labour intensive, but look for other campaigns that you can piggyback onto. The Gift for Living campaign is really nice. They've got some great resources. You may, depending on your practice demographic, you may want some specific cold resources. Indigenous Australians have a reduced incidence of bowel cancer but are less likely to screen, and there is a national pilot project being developed. And at the moment, you can get promotional material from this website. June's Bowel Cancer Awareness Month, so now's a great time to think about ordering some of those resources, getting your website and your Facebook and Twitter accounts all loaded up with some great health promotion information on screening. And lastly, if you do something, evaluate it. Did it make a difference? It can be quite simple. People said, yes, I'm going to go and do that test. Did you get any compliments or complaints? How many hits on your Facebook page? Was your team spirit improved? And use all that to decide whether you might consider a long-term health promotion program for screening. Fortunately, you will have some patients who do have cancer, and I just wanted to bring your attention to this resource. You can download it. It's got some great information for helping you to plan care with your GP management plans for people with colorectal cancer. And lastly, encourage people to check the toilet after they've been for a poo. Especially important for people who are too old for screening or have decided they don't want to screen. And we have a GP in our practice. He tells everyone, turn around and have a look. If it's Hawthorn colours, it's fine. If it's St Kilda, see me. And apologies to those of you who are not from Victoria or have no interest in football. You'll have to find your own teams that with those similar colours if you want to use that with your patients. So thank you for listening, and I'll now hand back to Jane.
Thank you very much, Tracy. You had some great resources there that we'll share with the audience after the webinar. We're now going to invite questions from the audience. Can you please type your questions into the chat box at the bottom left-hand corner of your screen? And I'll start asking Tracy some questions that have already come up earlier in the webinar. So Michelle's asking, is the ColoVantage home bowel screening test the same as the FOBT?
I believe it's the same kind of test now. It didn't used to be, but you've really got those negatives that they're not going to be put onto the register, and they're not going to get that follow-up. So we wouldn't suggest asking people to go and get that test rather than participate in the National Bowel Cancer Screening Program.
All right, thank you. And Tanya's asking, we get our FOBT through our pathology company. Should we encourage this over the government-free testing?
No, for the previous answer.
Okay, thank you. And Tracy's also asking, are demo kits available?
Yes, you can get a demo kit, but there is a link there. Nurses can get a demo kit, and they're fantastic.
All right, thanks for that. Now, Linda's asking, are kits still viable for use if left outside in extremely hot weather?
No.
And now Tanya is asking, if you start before the 50 with pathology kit, is it better to stay with the GP program rather than the government program?
Well, I would say it's better to go on a government program because of the follow-up, and also if you do have a positive test and you're in a place where they prioritise your colonoscopy, you're going to get your colonoscopy. It's supposed to be within 30 days.
All right. And the next question is there an actual letter of invitation somewhere where we can locate it online?
Yes, I put a link to that on one of the slides, and I believe you're going to get a copy of the slides, so you'll be able to go and have a look at that. It's on the National Bowel Cancer Screening Program website under resources.
Great. April's asking, if our practice requests FOBT for patients, does the bowel screening program want to know the results?
I believe they don't record it.
Okay. Laura's asking, can patients do screening independently from the GP? Do not need to see them unless FOBT positive, ?
Okay, sorry, I'm not sure what that question means.
Yeah, we might take that question on note and get back to it after the webinar. Patty's asking, Tracy, oh sorry, I'm just getting a heap of questions here, so my screen's flicking down to different questions. I'll just move on to the another question. What are the symptoms for bowel cancer, e.g. blood in the stool or pain?
Well, both of those are symptoms, and I think that question's probably better a medical question. But
yeah.
I don't know if Huey wants to add anything to that.
Huey, are you there and able to answer that question?
He wants to add anything to that.
Sure. So both of those could be indicators of bowel cancer. If blood is the more concerning over pain because there's plenty of evidence to show that bleeding is a more significant indicator of bowel cancer than abdominal pain. But unfortunately, they are very, very complicated symptoms, meaning that there are different qualities of pain, different locations, different natures, bleeding too. And by asking further questions, it might give us a stronger idea which way it's going to fall, whether there's a higher or lower likelihood of cancer. But in general, if blood is reported, then we would
Huey, for that. And we've probably got time for one more question.
Like a colonoscopy.
Myrna's asking how long the results take to come back. Yeah.
I don't know, but
yeah, we'll take that question on note as well and get back to people. So I would like to conclude that section of questions, and we'll take the ones we weren't able to answer in time and get back to you on those. We'll keep a copy of the questions that have been asked. So this now concludes our webinar, and we'll send you a link of the recorded session and a Q&A with the questions that have been asked. And also, when available, we're going to launch an updated version of the online module, a National Bowel Cancer Screening Program, and a hard copy decision support tool for nurses on the National Bowel Cancer Screening Program. So we'll also send you those resources on the National Bowel Cancer Screening Program. So we'll also send you those resources when available. My contact details are again on the screen if anyone wants to talk to me after the webinar. I'd like to thank Tracy and Huey very much for their presentations and taking time to answer questions. And thank you everybody for attending today's webinar, and I wish you a pleasant afternoon. Thank you.